Hello, welcome to MedEd 360. Today we are going to talk about one of the most common joint disorder, that is osteoarthritis. This is a condition that almost everyone has heard of. And if you have an aging parent or a grandparent, you have probably heard them complain about joint aches and pains. It's a widespread issue that affects millions of people, making everyday movements difficult and painful. So let's dive into what osteoarthritis is, why it happens, and how we can manage this painful condition to improve the quality of life. And if you are new to the channel, make sure to subscribe, like, and share this video so more people can learn about this important topic. Now let's get started. So what is osteoarthritis? Osteoarthritis is a slowly progressive, non-inflammatory, degenerative disease of the joints which primarily affects the hand joints, spine, and the weight-bearing joints of the lower limbs like knee and hip. It is also the leading cause of disability in elderly population, making it a major health concern worldwide. Now, how does osteoarthritis present itself? The most common symptom is dull joint pain that worsens with activity. This is an important distinction from the inflammatory arthritis like rheumatoid arthritis, where the pain actually improves with movement. Another key symptom is stiffness after prolonged immobility, a phenomenon known as gelling. Patient often describes a creaking, sandy, or a gritty sensation in the affected joint, almost like there's something rough inside when they move it. Unlike the inflammatory arthritis, osteoarthritis does not cause prolonged morning stiffness or systemic signs and symptoms of inflammation like fever or fatigue or weight loss. On physical examination, we might notice a crepitus, which is a grating or a crackling sound when the joint moves. This happens due to the roughened cartilage surfaces rubbing against each other. There may also be bony enlargement and mild swelling, especially in the knee joint. In long-standing cases, there may be joint instability and periarticular muscular atrophy, meaning the muscular weakness around the joint. Okay, so moving forward, let's talk about some of the epidemiological features of osteoarthritis. Osteoarthritis is more common in men under the age of 45. However, after the 45 years of age, women are affected more frequently than the men. This shift is believed to be due to hormonal changes, particularly the decline in the estrogen levels after menopause. The prevalence of osteoarthritis increases with age, meaning that older a person gets, the higher the risk of developing it. To put it to perspective, osteoarthritis affects about 20 to 30% of adult population. This is a significant number because it means that 1 in every 3 to 5 adults may be experiencing some form of joint degeneration. Considering the impact of osteoarthritis has on mobility and the quality of life, this makes it a major public health concern. Okay, let's talk about the pathophysiology of osteoarthritis, how and why it develops. Although the exact pathogenesis isn't fully understood, the main idea is that the repetitive trauma to the articular cartilage leads to damage. Once this damage occurs, it activates the immune system, triggering a cycle of cartilage breakdown and joint degeneration. This type of wear and tear damage mostly occurs in the joint that bear excessive loads like the knees and hips, or joints that are used repetitively like that of the hand joints. But here's an interesting twist. Osteoarthritis doesn't always happen due to excessive load. It can also occur in joints with normal loads when there's an underlying problem. This is called secondary osteoarthritis. In the secondary osteoarthritis, joint damage happens because of the pre-existing abnormalities in the cartilage, bone, synovium, ligaments, or muscles. So even if the joint isn't overloaded, it still deteriorates due to its weakened internal structure. This explains why osteoarthritis can develop in some younger individuals or in those with conditions like joint inflammation, past injuries, or metabolic disorders. After that, let's classify the osteoarthritis. It can be broadly divided into primary or idiopathic osteoarthritis and secondary osteoarthritis. The primary osteoarthritis can further be divided into localized osteoarthritis, where specific joints are affected, and generalized osteoarthritis, also known as Sjogren's syndrome, where multiple joints are involved. In the localized osteoarthritis, various joints can be affected, including hands, feet, hips, knees, and spine. One important subtype is nodal osteoarthritis, which specifically affects the small joints of the hands, including the distal interphalangeal joint, the proximal interphalangeal joints, and the carpometacarpal joints. Another subtype of the localized osteoarthritis is erosive osteoarthritis, also known as inflammatory osteoarthritis or Crane's disease. This is an aggressive form of primary osteoarthritis that typically affects the hand joints bilaterally. Unlike the regular osteoarthritis, the erosive osteoarthritis have some inflammatory features superimposed on the degenerative symptoms, which can make it look similar to rheumatoid arthritis or a psoriatic arthritis. However, the erosive form is different from the inflammatory arthritis because it does not cause any systemic inflammation. The inflammatory markers like CRP, ESR, and the autoantibodies like rheumatoid factor and ANA are normal. Okay, now let's talk about the generalized osteoarthritis or Sjogren's syndrome. In the generalized osteoarthritis, multiple joints, typically 4 or more, are involved symmetrically. This widespread joint degeneration can significantly impact the mobility and daily activities. Okay, on the other hand, the secondary osteoarthritis. This type of osteoarthritis is clinically similar to the primary osteoarthritis, but the key difference is that it has an identifiable cause. It also tends to affect joints that are not typically involved in the primary osteoarthritis, such as the metacarpophalangeal joints, the wrist joints, elbows, and shoulders. It can also involve the ankles and the metatarsophalangeal joints. The secondary osteoarthritis can also occur at an earlier age compared to the primary osteoarthritis. One classic example is the osteoarthritis of the metacarpophalangeal joints in a patient with hemochromatosis, a condition where excess iron deposition leads to joint damage. To sum up, the primary osteoarthritis is the more common type, occurring without an identifiable cause. On the other hand, the secondary osteoarthritis has a clear underlying cause, whether it's metabolic disorder, joint injuries, or systemic disease. In the primary osteoarthritis, it typically affects the weight-bearing joints and follows a gradual age-related progression, while in the secondary osteoarthritis, it can affect joints that are not usually involved in the primary osteoarthritis, and it may appear at a younger age. Understanding these differences is crucial for accurate diagnosis and treatment, as managing secondary osteoarthritis often requires addressing the underlying cause in addition to the symptomatic relief. Now that we have distinguished the primary and secondary osteoarthritis, let's explore the various causes that can lead to secondary osteoarthritis. These causes can be broadly categorized into congenital, mechanical, traumatic, metabolic, endocrine, neuropathic, and other conditions. So starting with the congenital disorder, some people are born with structural abnormalities that predisposes their joints to osteoarthritis later in the life. These can include hip conditions like disorders like leg calf Perthes disease, congenital hip dislocation, and femoroacetabular impingement. These can alter the joint mechanics, leading to early cartilage wear and development of osteoarthritis. Another class of disease is dysplasias. Conditions like epiphyseal and spondyloepiphyseal dysplasias can affect the bone and cartilage development, increasing the risk of osteoarthritis. The second one is mechanical causes. Chronic joint misalignment or instability can cause abnormal wear and tear. Some of the examples include scoliosis, in which the spinal curvature imbalance can lead to uneven weight distribution, and osteoarthritis in the spine. The mechanical cause can be joint hypermobility syndrome, in which there is excessive joint movement increases stress on the cartilage, or varus valgus deformities. Varus means bow-legged and valgus means knock-kneed alignment, puts uneven pressure on the knee joint, accelerated degeneration. The third cause can be traumatic. Past injuries can predispose joints to early osteoarthritis. These traumas can be in the form of fractures involving the joint surface, or ACL tears, or meniscectomy. The fourth is metabolic causes. Certain metabolic disorders can contribute to the abnormal cartilage and bone metabolism. These conditions can include hemochromatosis, in which there is iron overload damages the cartilage, crystal deposition like gout or pseudogout, in which the crystals trigger the joint inflammation and degeneration, and lastly Gaucher disease, which is a lysosomal storage disorder that can affect the bone and joint integrity. The fifth cause is endocrine disorders. The hormonal imbalances can disrupt the joint hemostasis. These conditions can include acromegaly, hypothyroidism, and hyperparathyroidism. The sixth cause is neuropathic joints, also known as Charcot joint. The loss of joint sensation leads to excessive wear and damage. It can happen in conditions like diabetes or syphilis. Other causes include osteonecrosis and stages of the infectious and inflammatory arthritis. For example, chronic joint infections or inflammatory diseases like rheumatoid arthritis can eventually result in osteoarthritis. And lastly, the Paget's disease, in which excessive bone remodeling causes joint instability and osteoarthritis. These were some of the causes of secondary osteoarthritis. Okay, let me quickly talk about the joints that are typically involved in the primary idiopathic osteoarthritis. These joints include the distal interphalangeal joint and the proximal interphalangeal joints of the hands, the first carpometacarpal joints of the hand, acromioclavicular joint of the shoulder, hips, knees, first metatarsophalangeal joints of the feet, and the facet apophyseal joints of the cervical spine and the lumbosacral spine. There are some joints that are not typically involved in the primary osteoarthritis. These joints include wrists, elbows, shoulders, ankles, metacarpophalangeal joints of the hand, and second to fifth metatarsophalangeal joints of the feet. Involvement of these atypical joints should prompt a search for secondary causes of osteoarthritis. Okay, so we have covered the pathogenesis and the joint distribution. Let's talk about the pathological changes that occur in osteoarthritis. These changes progress over time, starting with early cartilage damage and eventually leading to joint deformity. In the early stage changes in the osteoarthritis, there is swelling of the articular cartilage. In response to the stress and injury, the cartilage initially swells due to the increased water retention. This is an early attempt at repair, but also makes the cartilage more vulnerable to damage. Apart from that, there is also loosening of the collagen framework. The collagen that normally provides the strength and structure to the cartilage weakens, making the tissue more fragile. There is also increased proteoglycan synthesis by the chondrocytes. The chondrocytes are basically the cartilage producing cells that trying to compensate by making more proteoglycans, which help retain water and maintain the cartilage structure. However, they also release enzymes that degrade the cartilage, leading to a destructive cycle. And lastly, there is increased water content in the cartilage, disrupting the normal balance of cartilage composition. Instead of making it more resilient, this weakens the cartilage and accelerates its breakdown. Now, after early stages comes the late stage changes in the osteoarthritis. There is breakdown of the proteoglycans. Over time, the degradative enzymes break down the proteoglycans faster than they can produce, leading to progressive cartilage loss. There is also thinning and softening of the articular cartilage, reducing its ability to absorb shock. This is why joint space narrowing is a hallmark finding on X-rays. There is also fissuring and cracking of the cartilage, exposing the underlying subchondral bone. As the weight is applied to the joint, the synovial fluid gets forced into the exposed bone, creating fluid-filled cavities known as subchondral cysts. These can also be seen on X-rays. The exposed bone thickens and harder in response to the stress, a process known as subchondral sclerosis. And lastly, the osteophyte or the bone spur formation, in which the bone tries to compensate by forming extra bony outgrowths called osteophytes. While meant to stabilize the joint, these actually contribute to the stiffness and pain. So in conclusion, all of these pathologic features progressively worsen over time, leading to a radiographic changes we see in the advanced osteoarthritis. Understanding these changes help us correlate the clinical symptoms with the imaging findings and tailor treatment accordingly. All these pathological changes I have discussed translate into the classic radiographic findings seen in osteoarthritis. These include the joint space narrowing, the subchondral sclerosis, the subchondral cyst or geodes, and the osteophytes or bony spurs. These findings help in diagnosing the osteoarthritis and differentiating it from the other joint diseases. I will show you these radiographic features later with actual X-ray image so you can visually identify them. After discussing the pathological features, let's focus on the radiographic features of osteoarthritis, which can be remembered using the ABCDES mnemonic. This is the same mnemonic we used for the radiographic findings of the rheumatoid arthritis. If you want to check that video, I have added the link in the description. Here we will explain these findings using a knee joint X-ray as an example. In the mnemonic, the A stands for ankylosing. Unlike the inflammatory arthritis, there is no ankylosing, that is fusion of bones in the osteoarthritis. However, the alignment abnormalities can occur due to cartilage loss and the joint instability. The B stands for bone changes. The bone mineralization is normal, which helps differentiate the osteoarthritis from conditions like osteoporosis. There can be subchondral sclerosis, that is thickening of the bone beneath the cartilage. It appears as white areas on the chest X-ray. There may be osteophytes, also known as bony spurs. They are visible along the joint margins, forming as a compensatory response to cartilage loss. The C stands for cartilage changes. The joint space narrowing in the osteoarthritis is non-uniform, meaning that different parts of the joints are affected unevenly. This is different from inflammatory arthritis, where narrowing tends to be more symmetrical, and there are no calcifications. The D stands for deformities. Heberden nodes, bony swelling at the distal interphalangeal joints of the fingers, or there can be Bouchard nodes, that are bony swellings at the proximal interphalangeal joints of the fingers. These nodes are a hallmark of osteoarthritis and can occur due to osteophyte formation. The E stands for erosions. Unlike the rheumatoid arthritis, the typical osteoarthritis does not have erosions. However, in erosive osteoarthritis, also known as Crane's syndrome, the X-rays show erosions with a characteristic Gull-wing appearance, which refers to the central erosions with adjacent bone proliferation resembling the shape of a seagull's wing. In the bone features, I have forgot to mention a very important point, that patients with osteoarthritis can have subchondral cysts, which are fluid-filled cavities within the bone, and they are a typical feature and should not be missed on X-rays. And lastly, the S stands for slow progression over years. Osteoarthritis is a slowly progressive disease that worsens over decades, unlike the inflammatory arthritis which can progress rapidly. So these ABCD features help in identifying the osteoarthritis on X-ray and differentiating it from other arthritic conditions. Recognizing these findings early allows for the better management and treatment planning. Now let's look at these two X-rays of the distal interphalangeal joint and the proximal interphalangeal joint of a patient with erosive osteoarthritis. Notice the erosions in the joints. These are a key feature. The most striking radiographic sign is the gull-wing appearance, which you can see clearly in these images. This gull-wing deformity is a hallmark of erosive osteoarthritis and helps differentiate it from the typical osteoarthritis. Okay, let me talk about the two classical clinical signs of osteoarthritis: the Heberden nodes and the Bouchard nodes. The Heberden nodes are bony nodules or osteophytes located on the distal interphalangeal joints, whereas the osteophytes that appear on the proximal interphalangeal joints are called the Bouchard nodes. The presence of these nodes is highly suggestive of a primary nodal osteoarthritis. This means that the patient likely has idiopathic osteoarthritis rather than a secondary cause of osteoarthritis such as metabolic or inflammatory conditions. These nodes can sometimes be painless, but in many cases they are associated with joint stiffness and deformity, limiting the finger movement over time. So when you see these bony nodules on a patient's hand, think of primary osteoarthritis, particularly the nodal osteoarthritis. Moving on further, let's discuss some of the risk factors associated with the development of osteoarthritis. Several risk factors contribute to the development, and understanding these risk factors can help with the early identification and prevention. Let's go through them one by one. The first is age. This is the strongest risk factor for osteoarthritis. As we age, the cartilage undergoes natural wear and tear, making it prone to breakdown. The ability of the chondrocytes to repair damaged cartilage also declines with age, contributing to the disease progression. Another risk factor is heredity. The family studies estimate that 50 to 60% of the primary osteoarthritis cases are heritable. Multiple genes have been implicated, particularly those involved in the cartilage metabolism and joint structure. Another risk factor is the gender. Before age 45, the osteoarthritis is more common in men, and after the age of 45, the osteoarthritis becomes more prevalent in women. Another major risk factor is obesity. I will discuss this at the end. Another risk factor is the previous joint injuries, particularly the meniscal tears, ligament injuries like ACL tears, and fractures. They can alter the joint biomechanics, leading to accelerated cartilage breakdown. Post-traumatic osteoarthritis is a well-recognized condition, particularly in the athletes and individuals with prior joint surgeries. Another risk factor is abnormal joint mechanics in conditions like hip dysplasias, varus or valgus knee deformities, and leg length discrepancies. It can increase the stress on the certain joints, leading to osteoarthritis over time. Smoking is another risk factor, though not a direct cause of osteoarthritis. The smoking has been linked to degenerative disc disease, increasing the risk of spinal osteoarthritis. Smoking may also reduce the blood flow to the cartilage, impairing its ability to heal and repair. Occupation and high-impact sports are also a risk factor. Jobs that involve repetitive joint stress, for example, heavy drill operators or construction workers, increase the risk of osteoarthritis. Certain sports such as ballet, boxing, basketball, and long-distance running can contribute to the accelerated joint wear and tear, particularly if the injuries are not properly managed. Now, let me talk about obesity. Why obesity is a major risk factor? Obesity can lead to two things that can increase the risk of osteoarthritis. Number one, Increased joint load. The knee joint experiences 3 to 5 times the body weight with every step. Studies have shown that every 5 kg of weight gain increases the risk of knee osteoarthritis by 36%. And conversely, reducing the weight results in decreased risk of knee osteoarthritis. The second thing that obesity does is activating the inflammatory pathway. Adipose tissue releases pro-inflammatory cytokines which promote the cartilage breakdown even in non-weight-bearing joints like the hands. So osteoarthritis is a multifactorial disease with age, genetics, obesity, joint injuries and mechanical factors playing major roles. The weight management is one of the most important effective modifiable risk factors. Losing weight not only reduces the risk of osteoarthritis but can also alleviate symptoms in affected individuals. Before moving on to the last chapter of this discussion, that is about the treatment, I would like to discuss some few key clinical points. Other investigations in the osteoarthritis mainly help to rule out inflammatory or infectious causes. Blood tests including ESR and CRP are usually normal in osteoarthritis, but elevated in inflammatory arthritis. Autoantibodies like rheumatoid factor and anti-nuclear antibodies are negative, helping differentiate the osteoarthritis from rheumatoid arthritis or lupus. Synovial fluid analysis typically shows clear fluid with low white cell count, no crystals, and negative cultures, distinguishing it from conditions like gout or septic arthritis. While X-rays are the primary imaging tool, MRI can detect early cartilage damage. Ultimately, osteoarthritis is diagnosed clinically with the radiographic confirmation, while these tests mainly serve to exclude other conditions. Now let's move on to the treatment strategies for osteoarthritis. The treatment of osteoarthritis involves non-pharmacologic, pharmacologic, and surgical approaches, with the non-pharmacologic interventions being the first step and always used alongside medications. So let's first discuss the non-pharmacological interventions. The most important aspect is patient education, helping them understand the disease and how to manage it effectively. Weight loss is crucial, as we have discussed earlier, with even a small reduction significantly lowering the risk and progression of knee osteoarthritis. Another intervention is about the occupational therapy that can help the patient adapt their daily activities to minimize the joint strain, while assistive aids like splint, braces, and joint protection devices can reduce stress on the affected joints. Modifying the daily activities to avoid excessive joint load is essential, but contrary to common belief, complete bed rest is not advised. Regular exercise, especially muscle strengthening and aerobic conditioning, is beneficial for knee and hip osteoarthritis, more so for the knee osteoarthritis. Exercise and muscle strengthening prevent the muscle atrophy and improve the joint function. Another intervention is offloading knee braces that can help stabilize the knee and reduce pain. Optimal footwear, including cushioned shoes or insoles, can provide better joint support, while ambulatory aids like canes, crutches, and walkers are useful for reducing the joint stress. For example, using a cane in the opposite hand can unload the hip joint by 25 to 40%. Similarly, cervical collars may help in cases involving the neck. Among topical treatments, lidocaine provides local pain relief, while capsaicin works by depleting the substance P in the nerve endings, reducing pain perception over time. Transcutaneous electrical nerve stimulation may help in pain management by altering the nerve signals. Superficial heat and cold applications can provide symptomatic relief, with heat improving circulation and stiffness, while the cold therapy reduces inflammation and pain. Acupuncture is another complementary therapy that some patients find beneficial. Now that we have covered the non-pharmacological measures, let's move on to the pharmacological treatment options. But before that, let me talk a little about the role of exercise in the management of osteoarthritis. Exercise plays a significant role in osteoarthritis management by improving the joint range of motion, function, and reducing pain. Additionally, studies suggest that regular exercise can enhance the psychological well-being in patients. The ideal exercise minimizes the weight-bearing stress while promoting joint mobility, muscle strengthening, and aerobic fitness. Low-impact activities such as cycling, swimming, and walking are excellent choices. Incorporating these exercises into the daily routine can help maintain joint health, improve overall function, and enhance the quality of life for individuals with osteoarthritis. Moving on to the pharmacological treatment of osteoarthritis. Osteoarthritis has no cure, and no medication can reverse its progression. Medical therapy aims to alleviate the symptoms and improve function. Painkillers such as acetaminophen and non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, or COX-2 inhibitors like celecoxib are commonly used. High-risk patients for oral NSAIDs may benefit from topical NSAIDs, tramadol, or duloxetine. While oral corticosteroids have no role, intra-articular corticosteroid injections can be used for the joints with inflammatory component. New therapies include viscosupplementation, where the hyaluron is injected into the joint, particularly the knee joint, to improve the lubrication and shock absorption. This treatment is for moderate osteoarthritis when the standard therapy fails. However, it has mixed results in clinical trials, with some studies showing benefits comparable to NSAIDs but with fewer GI side effects. Side effects of these viscosupplementation include local injection reaction and systemic allergic reactions, but it remains an option for selected patients. And with that, we come to the final chapter of our discussion, the surgical management of osteoarthritis. When all else fails, when medications no longer control the pain and when daily life becomes a struggle, surgery becomes the next step. The most definitive surgical treatment is total joint replacement, especially for the hip and knee. So when do we actually consider joint replacement? The first major indication is severe pain that no longer responds to medical therapy, particularly if it's intense enough to wake the patient up at night. The second indication is significant loss of joint function when simple tasks like walking a short distance or putting on shoes or even getting out of bed become extremely difficult. At this point, the joint replacement can dramatically improve the quality of life. Before I wrap up, I want to briefly touch on some of the newer therapies that are being explored. These include autologous chondrocyte implantation, where a patient's own cartilage cells are used to regenerate damaged areas. Abrasion and microfracture surgery, which aim to stimulate the cartilage repair. PRP injections, which uses platelet-rich plasma to promote healing. Mesenchymal stem cell injections, which is a promising but still developing approach. And lastly, genicular nerve blocks, which target the nerves responsible for knee pain. And that concludes our deep dive into the osteoarthritis. I hope you found this video informative and easy to understand. My goal is to make medical knowledge accessible, not just for doctors and students, but for anyone curious about health. If you found value in this video, please hit the like button, share it with others, and most importantly, subscribe to my channel so you don't miss future content. Until next time, take care, stay healthy, and I will see you in the next video. Goodbye.